Very good morning, ladies and gentlemen. First of all, I thank Dr. G Vijayakumar sir and organizing team for giving me this opportunity to talk on my topic on hypoglycemia diagnosis. Hypoglycemia is an emergency and it is one of the acute complications of diabetes mellitus we commonly encountered in the ER rooms. However, the brain constitutes only 2% of the total body weight. However, the utilization of glucose by brain is around 20% for proper cerebral function. Hypoglycemia, it is a clinical symptom with diverse cause in which low plasma glucose concentration which leads to symptoms and signs, and there is a resolution of signs and symptoms when the glucose concentration is raised. However, the diagnosis of hypoglycemia should not be stopped with only having checking the blood glucose level. It requires the fulfillment of Whipple trials. Whipple many years ago have given the strategy and formed 3 criteria to diagnose true hypoglycemia, and these 3 criteria are: number 1, symptoms associated with hypoglycemia, and symptoms are associated with low glucose level, and relief of symptoms with supplementation of glucose. This is a classical Whipple triad. When this triad is present, then it is called as true hypoglycemia. However, the hypoglycemia in diabetes is slightly different. It is defined as all episodes of abnormally low glucose concentration with or without symptoms. That is, even with hypoglycemic unawareness in diabetic can be included as a hypoglycemia that exposes the individual to the harm. This is modification of Whipple's triad. What is the cutoff? The ADA has given the cutoff of sugar level for a diabetic of less than 70 milligram. However, this cutoff value is often debatable. When few says that even the sugar less than 63, it is considered as a hypoglycemia. What are the clinical manifestations? In regarding to the clinical manifestation, it is broadly divided into autonomic symptoms and neuroglycemic symptoms. In autonomic symptoms, there will be broadly divided into sympathetic and parasympathetic. In case of sympathetic, the patient will be having palpitation, tremor, and anxiety, and in case of parasympathetic, they will be having sweating, hunger. All this comes under parasympathetic symptoms. What about neuroglycemic? There will be a decrease in concentration level, in coordination level, and confusion, drowsiness, and unable to concentrate. All this comes under the neuroglycemic symptoms. There are non-specific symptoms which may be nausea, tiredness, and headache. Hypoglycemic disorders. First of all, when you are going to see that hypoglycemic disorder, it is broadly classified into fasting and postprandial hypoglycemia. There are different set of classification, starting from physiological classification, etiological classification, and clinical classification. This is a clinical classification. Depending upon the fasting and postprandial hypoglycemia, it should be broadly divided. What is fasting hypoglycemia? When the fasting hypoglycemia occurs more than 5 years after a meal is called as fasting hypoglycemia. When it occurs less than 3 to 5 years, then it is called as postprandial hypoglycemia. Regarding postprandial hypoglycemia, the main symptoms with sympathetic symptoms will be present with secondary to increased consumption of refined sugars or increased carbohydrate consumption that may lead development to postprandial hypoglycemia. Not only that, any few gastric surgery like gastrectomy or alimentary surgery will develop into hypoglycemia. They are specifically called as alimentary hypoglycemia. The main mechanism for developing hypoglycemia in the postprandial, specifically in the alimentary surgery, is dumping syndrome. There is a rapid shift in fluid level which causes immediate increase in insulin level. Overall, there is a decrease in blood sugar level causing hypoglycemia. And one more thing is a dysglycemia, in which pre-diabetic or even in early type 2 diabetic, there is a deficient early insulin secretion. Thereby, it causes symptoms like hypoglycemia. Not only that, previously postprandial hypoglycemia is called as reactive hypoglycemia. Even in early stage of maturity onset diabetes and even few inborn errors of metabolism like hereditary fructose tolerance and galactosemia and idiopathic postprandial syndrome, which is a diagnosis of exclusion. All this can present with a postprandial hypoglycemia. Not only that, few directly develop into neuroglycemic symptoms like when you are going to consume unripe ackee fruit, or any patient underwent bariatric surgery, and in case of insulinoma, and in case of islet hypertrophy and non-insulinoma pancreatitis hypoglycemia, they can develop also postprandial hypoglycemia. What is NIPHS? It is a non-insulinoma pancreatitis hypoglycemia. It is adult type. Which is a diffuse hypertrophy of islet cell can be present. Mainly they will be presenting with postprandial severe neuroglycopenia. Usually in case of postprandial hypoglycemia, the 72-hour fast test will be negative. It is very rare. However, male are more predominant to develop NIPHS when compared to females. However, in case of insulinoma, the presentation will be more in females, and it can be diagnosed with a calcium stimulation test. Regarding insulinoma, it is localized islet cell tumor that can be present with increased hypoglycemia level. Usually, we had to do with basic investigation like plasma glucose, insulin, proinsulin, and C-peptide level has to be done. It can be diagnosed with a localization. However, the USG abdomen scan has no role in the diagnosing of insulinoma. Even non-contrast, low resolution CT scan also has a no role. In specific CT pancreatic protocol, even it has a sensitivity of around 60%, and we are going to miss with 30 to 40% of cases of insulinoma. The most diagnostic is endoscopic ultrasound, followed by gallium-68 DOTA PET scan as well as gallium exendin PET scan. It is the most sensitive and specific test to diagnose insulinoma. However, how we are going to diagnose postprandial hypoglycemia? Previously, we used to do extended GTD. For every 30 minutes, we will be having a frequent blood sugar. In this cases, even a normal patient develop hypoglycemia. So, extended GT is currently nowadays it is not used. We are using mixed meal diagnostic test. What is a mixed meal diagnostic test? We have to ask the patient to take a regular meal or a meal that causes hypoglycemia, and blood was collected every 30 minutes for 5 hours, and the sugar has to be monitored. Once the patient develops a sugar level of less than 60 milligram, then we have to do additional tests like proinsulin, insulin level, C-peptide, depending upon the patients. And if the symptoms of hypoglycemia develop in midway, then we have to take immediately all the critical sample has to be taken at the onset of hypoglycemic symptoms. These are the parameters that differentiate between exogenous hyperinsulinemia and endogenous hyperinsulinemia. In case of exogenous hyperinsulinemia, the insulin level will be very high. However, the C-peptide and proinsulin level will be very low, because the insulin is secreted from pre-proinsulin to proinsulin, and proinsulin will be converted into insulin as well as it will be equally secreted with the quantity of C-peptide level. So, whenever there is an increase in endogenous insulin only, the C-peptide as well as proinsulin level will be increased. In this case, we can differentiate from exogenous hyperinsulinemia from endogenous hyperinsulinemia, which may be caused because of insulinoma, NIPH, and insulin autoantibody or intake of sulfonylurea or non-sulfonuric cetocox. We just saw about postprandial hypoglycemia. What about fasting hypoglycemia? There are three main categories that comes under fasting hypoglycemia, which may be because of deficient glucose production, or because of overutilization of glucose, or because of dysregulation of glucose. First, we are going to see about deficient glucose production. We have normal insulin level, which may be because of hepatic dysfunction or endocrine dysfunction, or in case of sepsis. In case of hepatic dysfunction, mainly because of glycogen storage disorder, advanced stage of storage disorder, even hepatoma, they will be presenting with postprandial hypoglycemia. In case of endocrine dysfunction, Addison disease with decreased secretion of ACTH, and with hypopituitarism with decreased secretion of cortisol level and TSH, we have to think about hypopituitary, and with glucagon deficiency. In case of sepsis, there is increased secretion of toxin, which is because of associated with cytokine secretion, which causes increase in release of insulin. This causes hypoglycemia. Regarding the overutilization of glucose with elevated insulin levels may be seen with insulinoma, nephrocytoblastoma, autoantibodies against insulin or insulin inhibitor. The autoantibody against insulin or insulin receptors is otherwise called as Hirata disease. Few drugs like carbimazole and methimazole can produce antibodies against the insulin, thereby it causes hypoglycemia. Even few drugs like alpha lipoic acid, which is commonly used in neuropathy as well as clopidogrel, even such drugs can cause autoantibody against insulin and insulin receptor, thereby it can cause hypoglycemia. And one more thing is inappropriate insulin level. Few extrapancreatic tumors and cachexia with fat depletion and systemic carnitine deficiency can also cause hypoglycemia. Not only that, substrate deficiency like chronic starvation, chronic renal failure, and ketotic hypoglycemia of infancy can cause hypoglycemia. And this is a compromised glucose counter regulation. Fix the syndrome. Fix this because of defective glucose counter regulation, and hypoglycemic unawareness comes against the fixed syndrome. What about the dynamic syndrome? Extensive and intensive use of insulin therapy can cause hypoglycemia, and recent androgen hypoglycemia or recurrent hypoglycemia, and any patient with drugs like adrenergic antagonists can also cause fasting hypoglycemia. There are few drugs like salicylate, propranolol, pentamide, quinine, even gratifloxacin can cause hypoglycemia. We just saw about postprandial hypoglycemia and fasting hypoglycemia. How we are going to diagnose, evaluate, and investigate with fasting hypoglycemia? First, good clinical history has to be taken, and any history of liver failure, sepsis, and autoimmune disease, and neoplasm, and alcohol drugs has to be taken into account. Then we have to do a supervised 72-hour fast test. It is usually done in the hospital setting because there is a low risk for the patient. Usually, in case of hypoglycemia, all this patient will be developing symptoms and signs within 48 hours of starting the test. What is the 72-hour fast test? What is the protocol? Actually, it is a very painful test. Most of the patient will be giving up or doctor will be giving up. The protocol is, first we have to document time and date of onset of fast as the time of last intake of calories has to be documented. We have to discontinue all the essential, non-essential medications and allow the patient to drink calorie-free or caffeine-free beverages can be taken, and blood sample has to be measured, plasma glucose, insulin, proinsulin, C-peptide every 6 hours until the patient has a plasma glucose concentration below 60. We have to document. Once the patient has reached the plasma glucose of less than 60, the sampling should be done every 1 to 2 hours. When you are going to stop this test? Once the patient has the blood sugar of less than 45, we have to stop performing this test, and when the patient has the symptoms and signs of hypo, and when the patient has completed 72 hours without any symptoms, we have to stop this. Not only that, we have to do plasma beta hydroxybutyrate, which is a curant, and the sulfonylurea level also has to be monitored. After that, we have to give glucagon. 1 mg should be given intravenously, and glucose has to be measured. When there is an increase in blood sugar of more than 1.4 millimole, then we have to take into account. In normal subject, usually the following threshold have been identified in the graded glucose reduction. Once the patient develops hypoglycemia, the first thing that will be taking place will be there is a decreased secretion of insulin, followed by increase in glucagon level. Thereby, it has to maintain the plasma glucose, followed by other catechol like cortisol, epinephrine, and growth hormone will also be taken into account. In case of normal subject, the patient doesn't develop any symptomatic hypoglycemia even after the prolonged fasting, mainly because of the glucogenesis, which accounts for approximately 50% of the glucose production after an overnight fast. How are we going to interpret? For normal patient, there will be no symptoms, and the blood glucose will be more than 40, and insulin level will be less than 3, C-peptide less than 200, and proinsulin level will be 5. We are going to see about insulinoma, which is blood sugar will be less than 45 with insulin level more than 3 and proinsulin level more than 5 with C-peptide level more than 200. Then we have to think about it is because of insulinoma. In case of factious hypoglycemia from insulin, with the usage of excess insulin, the patient will be having less sugar. However, the insulin level will be also more, but in case of factious, the C-peptide level and proinsulin level will be very low, so that we can differentiate from the factious hypoglycemia from the insulinoma. Regarding sulfonylurea induced hypoglycemia, the patient will be having high insulin level and increase in C-peptide and increase in proinsulin. However, the serum beta hydroxylase level will be less than 2.7. And one more thing, the drugs will be sulfonylurea will be present in the serum. In case of hypoglycemia mediated with insulin-like growth factors, blood sugar will be less than 45 with C-peptide will be less than more than 3. Less than 200 with insulin level less than 2 and proinsulin level less than 5, then patient will be having hypoglycemia mediated by insulin growth factors. However, in this case, the beta hydroxybutyrate will be less than 2.7. In non-insulin mediated hypoglycemia, sugar level will be less than 45 and insulin level less than 3, 200 C-peptide less than 5 in proinsulin. However, in case of non-insulin mediated hypoglycemia, the serum beta hydroxylase will be more than 2.7. This is a major diagnostic interpretation by doing a 72-hour fast test. And in this, mainly because insulin autoimmune and insulin receptor autoimmune. In case of insulin autoimmune, the insulin level will be high, C-peptide will be high, and proinsulin will also high. The antibody will against the insulin will be present. However, in case of insulin receptor autoantibody, the insulin will be high, but C-peptide proinsulin will be low. This is the main difference between insulin autoimmune and insulin receptor autoimmune diagnosis. And this is the overall slide. However, when the patient comes with hypoglycemia, we have to investigate, evaluate in the background of patient with diabetes and without diabetes. In case of diabetes, there are few set of diseases, mainly because of food OHI mismatch or food insulin mismatch, or skipping of meal will be the common reason for developing hypoglycemia in case of diabetic patient. However, in a non-diabetic patient, we have to think about whether because of fasting hypoglycemia or postprandial hypoglycemia. As I already said, in case of postprandial hypoglycemia, we have to do a mixed meal test, and depending upon the sugar response, we have to diagnose further, and set of disease can be diagnosed. In case of fasting hypoglycemia, once the blood sugar is less than 2.8, we have to check about the insulin level, whether it is lower in level or in the more than 3. Then we have to check about C-peptide level, which is less than 200 micromoles or more than 200 micromoles. Depending upon the classification, we can diagnose further. Once the patient has a C-peptide level of more than 0.2, we have to think about OHS. This is my summary. To summarize, a good clinical history has to be taken. We have to think about whether the patient is having diabetes or not without diabetes, and biochemical investigation like plasma glucose, C-peptide, insulin, pro-insulin level has to be taken. If possible, try to do an beta-hydroxybutyrate, and any serum cortisol, TSH and ACTH can be taken to think about any fasting hypoglycemia. Usually take the critical sample at the onset of hypoglycemia, not at the end of hypoglycemia or after treating the hypoglycemia. For taking to diagnose any fasting hypoglycemia and set of disease, we have to do a 72-hour fast test. In case of to diagnose any postprandial hypoglycemia, we have to think about and we have to do a mixed meal diagnostic. I thank chairperson for giving this wonderful opportunity. Thank you, sir.
Thank you, Dr.